Good morning, Dr. Sengupta. Today is our last day of class, as well as the day to turn in the Unit 4 case presentation. Pardon all my emails this morning as a foreshadow. I was up early this morning and was on ProctorU trying to find an exam, but it seemingly was straightened out. Nonetheless, for today, I chose the case 3 as well as case 4. And starting with our first clinical case here. So patients can be quite honest or untruthful when it comes to you questioning what brings them in today. Why are they here seeing you? Coming from clinical exercise physiology, which I've stated before, gout really wasn't too common in a lot of patients I saw due to their dietary intake already being monitored because of having a previous myocardial infarction or some sort of cardiovascular ailment. But there were occasions that some patients did have gout. So when they are dishonest about their intake, it kind of makes your detective work a little more cumbersome. Nonetheless, this man already stated that he drinks roughly 4 to 5 liters of pure soda, you know, the real sugar, not the non-sugar, the fake one or diet, whatever you want to call it, which has been shown to be equally as detrimental to your health in the long run, the aspartame and the fake sugars anyway. But nonetheless, he goes and he drinks 5 liters of primarily sweetened by high fructose corn syrup soda a day. And our bodies break down fructose into purine and ultimately uric acid. And so this is ultimately what leads to gout. Pardon me. What leads to gout, and this can't be filtered out by the kidneys if it's especially in excess, and that ultimately gets stored in the joints as uric acid crystals. And so the picture on the right here kind of shows, you know, a big ouchie there. They have a giant swelling around that joint that's being affected, as you can see, and it renders that joint pretty much immobile. The big toe is always seemingly one of the places that people experience gout, being very distal in the body, and a joint that's mobile all day long. So with that joint being immobile, a lot of individuals will seek treatment or therapy or try and research some home remedies that can alleviate some of these symptoms, with the primary one being dietary change. You know, if they consume a lot of lunch meat, which is high in nitrates, or organ meats, big game meats, these things that are high in sodium as well as produce uric acid is going to worsen the problem or keep the problem ongoing. Also, excessive alcohol consumption or beers, primarily. Beers are high in purines, which then, as we stated, gets broken down into uric acid. So if someone's an alcoholic and drinks multiple beers a week, multiple beers a day, them working towards cessation of that is really going to work in their benefit to help avoid flare-ups, which can happen and do happen with these individuals. So the questions here: overproduction of purines. So purines are broken down further into uric acid. Excess purine disables the kidney functions to filter these out, and the uric acid becomes stored in the joints in the form of crystalline structures, which we talked about, that of course are sensed by the individual and experiencing pain. So the first option there most certainly would lead to gout. However, the second option, decreased salvage of purines, would be an incorrect choice, because purine consumption increases. As purine consumption increases, more is converted to uric acid, and thus increasing the person's opportunity to develop gout. The decreased salvage of purines is more applicable in the scenario of forming purine nucleotides from sugars. So they're already consuming high sugars, so increasing the salvage of the purines isn't going to decrease their chance of having gout. However, decreased urinary excretion of uric acid most certainly would as well. This is also an indicator of gout. When they check a patient's urine, they're looking for the urea or the uric acid that's present in their urine, and a decreased amount in the urine would certainly be indicative of a patient having gout, especially if they have a physical symptom like a swelling in around their greater toe there, as well as pain upon ambulation. So dietary modification for this individual we've kind of talked about already, decreasing sodium, alcohol consumption, increasing water intake, trying to get that filtered out more readily, more often. And they can also look into increasing their supplement intake for gout. I've had some patients say that turmeric is one of the best natural remedies that you can consume to help decrease that inflammation. The B vitamin complex, as well as omega-3 fatty acids from fish oils, also have shown to improve the symptoms of gout. Now, not to be confused with the actual seafood that are high in purines, especially when you go to like Red Lobster or something like that. This is just purely talking about the supplementation of omega-3s and avoidance of the high fructose corn syrup sugars, or beverages or foods. Vegetables, whole grains, low-fat dairy products may also be viable nutritional sources for these individuals. So this was pretty cool. This was pretty relevant. I liked reading about the pathways of how uric acid is formed and how it gets stored. Why does it get stored in intra-articular spaces is the question. So the second case that I researched here was case 4 about the 58-year-old female, and the questions were regarding supplementation and deficiencies in these supplements or deficiencies in these complexes. Would they more or less lead to this megaloblastic anemia? So the first one being iron, and we know that iron is directly related to anemia and hemoglobin's capacity for binding to oxygen. So a deficiency in iron immediately sparks the thought of anemia, in which there is a reduction in healthy red blood cells to carry oxygenated blood tissues throughout the body. However, a deficiency in vitamin B6 has been shown to cause microcytic anemia, which I had never heard of before. Is defined as the presence of small, often hypochromic, which means they're less in color. They have less color in the red blood cell. In a peripheral blood smear, and is usually characterized by a low MCV, another term that I hadn't come across before, otherwise known as the mean corpuscular volume, or the average size and volume of the red blood cell. So they see that in megaloblastic anemic cells, they appear larger. They physically are larger. And the last one was vitamin B12. A deficiency in vitamin B12 would impair purine and pyrimidine metabolism. This transpires by a reduction of pyrimidine deoxythymidine triphosphate. So I hadn't heard of a lot of these before, besides when we were doing our labs, as well as our our sections of reading, as well as researching this topic. So pardon my mispronunciation here. This can also happen by mechanism involving dihydrofolate reductase inhibitors, which ultimately reduces the availability of coenzyme myethylene tetrahydrofolate, which is required for thymidylate synthase. So a lot of enzymes there, a lot of pathways that vitamin B12 is actually involved in the metabolism of purine and pyrimidine. So iron and B12 would certainly be the most standout of these, with B12 being the focal point. And the question then comes to, what other lab values would you be interested in ordering? And my initial thought would be, we got to see a CBC. We want to see the red blood cells, the platelets, the white blood cells, as well as look at that MCV, or that volume of that red blood cell itself. And after doing some research on megaloblastic anemia, I believe we would see low hemoglobin. I think there would be with this person being anemic, we would see low hemoglobin values, as well as an elevated MCV, and decreased platelets and white blood cells, which ultimately would spark my interest in potentially having the patient participate in a bone marrow aspiration, so we can evaluate for thrombocytopenia or decreased platelet counts all around. So, like I said, pardon my mispronunciations here, but I thought these two labs were pretty interesting as far as supplementation, biochemistry, physiology, and how they all tie into a person's overall well-being. And I'm sure a lot of these things we're going to see in the field. It's going to become quite the challenge, especially going into primary care for individuals that are interested in that, as well as doing rotations through there. All of this knowledge from this course, I believe, is going to be quite applicable. I may not remember all of this stuff offhand, but it locks into place the rationale behind why treatments are what they are and why a diagnosis would be what it is. So thank you, Dr. Sengupta, and I'm sure I will talk to you soon.